Hi, I'm Ian Glenn from Akron Children's Hospital. Thank you for the opportunity to speak. Today I'm going to be talking to you about surgical telementoring and its use in the rural surgical environment. Oh, that's not my first slide. Oh, cool, thanks. So I have no disclosures. You can see disclosures for our group. So for those of you who heard Dr. Duncan's excellent presidential address today, you know that surgical telementoring has a lot of promise, and I'm here to talk about what is surgical telementoring and is this something that's worth our time. So at its most fundamental level, surgical telementoring involves an expert surgeon guiding a less surgeon remotely through a case. In our experience, this can be as simple as two surgeons being in the same hospital, one room apart, or literally on other sides of the globe. As you can see from the picture here, Dr. Steve Rothenberg's on the right side in Colorado. Dr. Ponsky's operating on the left side in Ohio doing a lung resection. So while there is a lot of excitement around surgical telementoring, there's been some debate as to whether this is something that will really garner widespread interest. So the purpose of our study was to assess the interest of rural surgeons in surgical telementoring, and ultimately we would like to demonstrate that there is widespread interest. This is something that warrants widespread adoption, and that it's worth investment of time and money on the part of physicians and hospitals and industry. So you might be asking why we decided to investigate starting with rural surgeons. So unlike surgeons who are practicing in a tertiary hospital where they have access to a wide number of colleagues with a cumulatively very large skill set, rural surgeons are often practicing on their own or with just a small group, and they may have complex patients who they want to retain ownership of without having to transfer these patients to a tertiary hospital. So we polled rural surgeons from the ACS Advisory Council for Rural Surgery. We sent them an online survey explaining the purpose of our study. This was accompanied by a short video demonstrating some of the capabilities of surgical telementoring, as well as some questions assessing their interest. So you can see we had a good response here, and the majority of the surgeons were indeed practicing in small communities which would qualify as rural environments. And as you can see from the histogram here on the bottom, the majority of our surgeons were practicing 10 years or more in a rural surgical environment. So starting off, you can see here that 79% of rural surgeons stated that they were indeed perceiving surgical telementoring as something that would be useful to their practice. So once we've established that surgical telementoring is something that rural surgeons would think would be useful, we want to get into the how and the why. So there's two main schools of thought regarding the use of surgical telementoring, and the answers that the respondents gave pretty much reflect these two schools of thought. One states that surgical telementoring should be part of a curriculum for learning new skills. So a surgeon, for example, would attend a course in person, learn new skills, go back to his or her home institution, and the surgical telementoring would be a way for the teacher to keep an eye on the student and continue to ensure that learning goes along the correct pathway. The other option is the help button. So a surgeon is in a case, there's an unexpected finding, you break the glass, hit the button on the wall, and somebody can beam into your OR and help you with something unexpected or very challenging. So next we asked a similar question, but now we said, tell us all the ways in which you would be interested in using surgical telementoring. 70% of the respondents said they would use it for intra-op consultation for unexpected findings, which is the help button. And then you can see they were interested in a broad range of other new skills which they'd be interested in acquiring. So now getting to the financial discussion, 70% of respondents said that they did think that surgical telementoring would be financially beneficial to their hospital, but almost half were unsure if this is something that their hospital would actually be interested in paying for. So speaking of payment, how should the telementor be compensated for his time? And the answer kind of spans all levels of the healthcare system. Should payment be made by the Affordable Care Organization at the top, right, at the health system level? Should this be hospital-based? Or should the services be paid for only by the telementee, the person who's receiving the training? Or should this just be limited to learning new skills through a course? So just briefly looking at some of the responses here, we performed a Fisher's exact test, and there was no significant difference in the proportions between years in practice and perceived usefulness. So what that means is the perceived usefulness of surgical telementoring was not related to the amount of time that a surgeon has spent practicing. So we conclude that there is indeed widespread interest in surgeons in the rural environment in telementoring, and that is an area that is justified in performing future research and further development of this technology. Like any new technology, there are indeed some obstacles to broader adoption, and broadly that can be classified into these 4 categories. And the big questions associated with this become, is this something that we can widely implement in a safe, reliable, and affordable fashion? What about the legal questions? So how will medical liability be handled, particularly when this technology is anticipated to be used both in an interstate fashion or even internationally? And then who will pay for all of this, maybe the biggest question. And then finally, what will patients think of all of this? Thank you.